Hello, everyone, and welcome to the webinar. We will be starting shortly in about 32 minutes from now, which will be about 12 p.m. Malay time. And I hope you are having a wonderful day. Feel free to share the event with your friends and colleagues. It will be really nice to learn together. And like all our previous meetings, I will be sharing the link to download the certificate in the Zoom chat box. And after that, just send me the request, and I will allows you to access your certificate a couple of hours after the webinar ends. And it's a Google link, and you will be able to download it easily. So if there's another new feature that I have added for all of our participants, and you will certainly like it, because I'm going to have a Zoom virtual group photo after the webinar, so you will be able to have a memory of the webinar with you and with the respective professor. Will be something that we used to do. It was something that we used to do, and we still do whenever we have the opportunity to get ourselves photographed with our mentors and colleagues and seniors. And whenever we attend a conference, an interaction conference, we usually have this group photo. So I do think that while we have launched all this virtual platform, everything should be mimicked virtually as well, so that we can have a good memory of what of us being with our legendary teachers. So it will be a new addition. So those of you who would like to get involved and get groupie, just turn your videos on at that time, and I will say, and just get a picture done. I will send it to you in the WhatsApp group. I kindly request you to please mute your mics and turn your video off during the webinar. After the webinar, we will ask everyone, we will request everyone to open their videos so that we can have the group photo. Thank you. Kindly keep yourself muted and keep your mics off as well. Dr. Harshad, kindly. Hello everyone, I have just shared the WhatsApp group address. It would be so nice if you can join our WhatsApp group to stay updated and to get all those resources that we share. Thank you. Hi, sir. Thank you very much for joining us today. Hi, sir.
Sorry.
Hi,
Okay.
sir. Thank you so much, sir.
My pleasure. Okay, I'm going to put that way. Maybe. Okay, brighter. Okay, how are you?
I'm doing great, sir. Thank you.
What about your week? Very busy?
Yes, sir. Yes, sir. Exactly. So it was something quite busy for me as usual, but it was so nice to plan this wonderful webinar. And sir, how was your week? Sir, how was your Easter?
Well, very busy practice, a lot of cases, but thanking God every day, you know.
Exactly.
I'm very happy to join you all again. And I'm ready to give my talk. I hope I can, let's say, you know, give some ideas or some clues. Well, my lectures trying to give some anatomical tips and practical tips after, you know, many years devoted to skull-base surgery. I like to transmit what I have learned, case by case. That's all, humbly.
Thank you so much, sir. It means so much to us, especially to the neurosurgeons of my age and of our age. It means a lot, sir. So the previous lecture was so amazing. Everyone liked it so much, and it was so generous and so kind of you, sir. Actually, who spared time from your very busy schedule. We know that that you have such a busy schedule, but still you spares time to share your knowledge with us and to fund your surgical education, which means so much to us, sir. Again, thank you very much. The lecture is so amazing. I hope that everyone is also already quite excited to listen to this lecture, because it is going to be an extremely important lecture, sir. So again, thank you.
Thank you. Okay, just give me 15 seconds. I'm going to bring to take a charger just in case. I don't want to interrupt my talk. 15 seconds.
Sure, sir, please. So again, as you can see, Professor Miguel, right, does not need any introduction, but I'm pleased to still tell you a couple of words about Professor Miguel Arraez. He is the professor and chairman of the Department of Neurosurgery in Carlos Hayes University Hospital. He is the first vice president of the WFNS, and he's also the president of the World Academy of Neurological Surgery. So as most of us know who are enthusiastic about neurosurgery, that Professor Miguel, right, it's really he's a legend of neurosurgery. So he's a master. So it was a matter of real honor for me to have this privilege of organizing this webinar with Professor Arraez, and to have this second episode with him. The first episode was studied by many of you. So again, today Professor will be delivering a lecture on surgery in and around the Meckel's cave. So again, sir, thank you very much for spending your time today for to deliver this amazing lecture, and we are also excited to have you with us again. So I'm stopping my screen share to allow you to kindly share your screen, sir.
Okay, thank you very much. Appreciate Dr. Noor. Thank you very much again for your kind invitation. It is for me a great pleasure to be again among you all. We are, you know, thousands of kilometers far from each other, but I feel you all very close. We are in family, and thank you again for giving me the opportunity to share my experience. The topic today is, I hope you can see my screen. Right?
Yes, sir, we can.
Okay, 1 second. I'm going to okay. Okay, excellent. 1 second. So, well, the topic today is surgery in and around Meckel's cave. And well, I have to mention that this is a region we can approach by means of classical microsurgical skull-based approaches, or by means of endoscopy, because the new endoscopic technique is beautiful in many fields in skull base, and Meckel's cave is one of the indication nowadays. So we also, at the end of my talk, we try to give some clues about the better approach according to the anatomical location of the tumor. Let's mention that as we have said, this is a sort of area anatomy. We have to know very well the anatomy of this area. We can see top on left, we can see one of the slides of Professor Vinko Doleng, and we can see this is the left side. This is the petrous apex, the bony area itself. This is the fifth nerve. This is the Gasserian ganglion. This is the third division, second division, first division. We can see carotid artery over here, and this is GSPN, greater superficial petrosal nerve. I like to call the attention regarding that tissue. What we are seeing is an anatomical preparation without any drilling. It means that in that area, when you are doing the exposure of the temporal fossa, maybe you can directly see carotid artery or carotid artery with a very thin layer of bone or some cartilaginous layer. So it means that if you are trusting that all you are going to find is only bone, you can have a terrible surprise, because if you are doing a sharp dissection, you can damage carotid artery. This is something very important. This is the superior petrosal sinus, that is another structures inside the dura mater, one of the folding of the dura mater, that are also that is also important to be taken into account. This slide, some of them are coming from the 3D neuroanatomy group of Dr. Pablo González from Alicante and his colleagues. Wonderful group with beautiful anatomical lab work, and we can see the relationship. This is the right side. This is tentorial incisura. We can see the cavernous sinus. We can see the initial part of the Gasser ganglion with the first, second, and third division, and we can have some idea of the relationship with the petrous apex. The petrous apex has been drilled a little bit. So if we go to bottom left, we are saying the superior petrosal sinus. We are seeing just the trigeminal nerve getting inside Meckel's cave. And this is the drill of the petrous bone that allows us to see the content of the posterior fossa. So it means that through the petrous apex, we can reach the posterior fossa, that is called extended middle fossa approach. And just bottom right, you can see this more comprehensive view, because we are seeing the bone. The petrous apex itself has been drilled. What we have underneath is the inferior petrosal sinus. We have to take that into account, because if we drill just going down and down, we will get inside the inferior petrosal sinus. If we go laterally, we can even get inside the jugular valve that, as you know, has a very variable anatomy. This is the cochlear structure. This is the petrous carotid artery. We are seeing here the fifth nerve converted into a Gasserian ganglion, and then divided into the three branches. From this area, laterally and inferiorly, we are seeing the intradural and posterior fossa content. And of course, this is the content of the internal auditory canal that we also have to take into account, because we will see later on that when drilling the petrous apex, if you go in that lateral and posterior fashion, you will find the internal auditory canal. But you will have some idea that you are approaching that area because the cancellous bone is converted into more firm and dense bony structure. So this is something we have to take into account. This is the fourth nerve. This is the fifth nerve. Sixth nerve is supposed to be underneath, and the sixth nerve is entering the Dorello canal. And this is the way you have to take into account not only the petrous bone, not only the Meckel's cave, but also all neurovascular structure around. And how to approach that area? If we are just facing the first possibility, that is the transcranial approach to the Meckel's cave and petrous bone, these are several steps we always have to take into account. We have to do a craniotomy, that can be a temporal craniotomy, frontotemporal craniotomy. Sometimes you may add a zygomatic osteotomy. I have to mention that the cranio-orbito-zygomatic approach is not necessary for that, just in case some limited zygomatic osteotomy that has the usefulness of allowing you to reflect downward the temporal muscle and diminishing so retraction of the temporal lobe. After that, we will identify the middle meningeal artery. Middle meningeal artery is the most lateral structure, sometimes surrounded by venous structure, sometimes with a troublesome bleeding that may need some bone walks. And just medial to that, we will find the third division of the trigeminal nerve. And medial to that, we can see here in this area, this is left side, and medial to the third division, we will find GSPN and the internal carotid artery, basically the petrous carotid artery. So these are always a step we have to do. It's important to incorporate the concept of the peeling of the fifth nerve, because the fifth nerve is since the moment the fifth nerve is getting inside Meckel's cave, the structures of the Gasserian ganglion are completely extradural, as you can see here. So we have to manage to find the plane between the dura mater and the Gasserian ganglion, as you can see here. And we will see several possibilities. One, the first possibility, according to the location of the pathology, is related to lesion very much restricted to the petrous bone. The classical example is cholesterol granuloma. You can see here one of these examples in one young patient. This is carotid artery, and petrous apex is always medial to the petrous carotid artery. As you can see here, occupied by the lesion. This is the incision you can do, and you can do this limited zygomatic osteotomy that, as I mentioned before, is useful to retract the temporal muscle, exposing the temporal area, and after craniotomy, allowing you to retract laterally and superiorly the temporal lobe. So after that, we have the exposure. What we are seeing, just this dark area, is muscle, is the infratemporal fossa. So we have reached the limit of our exposure, just reflecting downwards temporal muscle after having done the zygomatic osteotomy. Then you can do a craniotomy. You can see the dura mater. We are, of course, at the right side. This is the Gasserian ganglion. You can see the third division, second division. This is petrous carotid artery. Medial to the petrous carotid artery, we can see the lesion. that has the solid 60th classical appearance of cholesterol granuloma. I like to call the attention in regard to cholesterol granuloma about the indication. Very frequently in our practice, we will see cholesterol granuloma, that is a complete benign entity. And we have to plan the operation only in symptomatic cases. This is one cholesterol granuloma operated on many years ago. The anatomy of the CT scan is giving you again the order of the structure you have to expose. The more lateral is the middle meningeal artery. Immediately after, you will find the third division of the trigeminal nerve. This is, as a matter of fact, this is foramen ovale. And then you will find carotid artery that is supposed to be over here, and medial to the carotid artery is cholesterol granuloma. This case was operated on maybe in the early 90s, maybe 91 or in the late 80s. And at that time, the peeling of the trigeminal nerve was not very much extended. So what we used to do at the beginning in our cases was just to cut the third division of the trigeminal nerve. So that way you can expose completely the carotid artery. This is the left side. This is the loop of the carotid artery, first loop, and second loop right before getting inside cavernous sinus. This is the only way of just having this view of the second loop is just cutting the third division. After that, we use to suture the third division with the hope of having some recovery for from the motor point of view. But now this practice has been abandoned because we now take advantage of the peeling that allows you to expose in a very good in a pretty good way the petrous apex. And you have seen here the petrous apex after removal of the cholesterol granuloma. The patient was operated on in my former institution in Granada many years ago, and the patient was lost for the follow-up, and the patient came many years after to Malaga, my current institution, and you can see this huge recurrency of the cholesterol granuloma. These are lower cranial nerves, and this is a retrosigmoid, classical retrosigmoid exposure, and you can see the lesion with this huge recurrence. So do not underestimate the potential severity of the cholesterol granuloma. You have to take into account whether the lesion is growing or not, and also if the lesion is growing, try to be radical or try to solve the problem, avoiding recurrence. Another classical indication for this approach is chondrosarcoma. You can see the typical pattern at the CT scan. You can see this pattern at the MRI, and this is postoperative CT scan. You can see the removal, some hemostatic material, in that case inside the intradural space. And this is another chondrosarcoma. You can see the way the chondrosarcoma is displacing the petrous carotid artery, and the way chondrosarcoma sometimes likes to break the dura mater and get inside the posterior fossa. You can see this initial stage of the lesion, also here, bottom left, and right after complete removal of the lesion through what we can call transpetrous resection. The second group of lesion could be in this location, at the extradural and interdural space. This is synonymous of Gasserian ganglion, that is to say lesion involving with the epicenter the Meckel's cave. 99% of the cases are lesions that are involving the trigeminal nerve. And we can see one of these examples. This is a patient, psychiatrist, with episodes of intense headache, facial pain, and diplopia. We can see the Gasserian Meckel's cave at the left side. At the right side, we can see this lesion, and we can depict the two layers that are giving the idea that that lesion are extradural, but at the same time interdural between the dura mater lateral to the cavernous sinus and the other dura mater medial to the temporal lobe. You can see the lesion over here. You can see the appearance of the lesion. And how to get there? Well, there are many descriptions of the same concept. I think one of the beauties of skull base is the possibility for all of us to do exactly the same, but giving different denominations, eponyms, and so on. Epidural, interdural approach, frontotemporal approach, infratemporal, fossa interdural approach, taken from Dr. Goel or Dr. Dolen. Basically, what we have to do, if we look at the picture, is just making an extradural exposure according to what we have seen in the anatomy. And then this is the layer you have to spare, that is the dura mater. So you will expose the Gasserian ganglion and the third division of the trigeminal nerve. Sorry. Several concepts. We have seen here porus trigeminalis. Porus trigeminalis is exactly the point where the trigeminal nerve, after its cisternal segment, is getting inside Meckel's cave. You can see Meckel's cave over here, and Meckel's cave can have more or less CSF. You can see here some CSF. This is normal. And the Gasserian ganglion is, in 99% of the cases, the origin of the lesion in that interdural, extradural location. This is the example, and I like to call your attention about one fact. There is a very much difference from case to case. The anatomy of the venous structure is quite different, and sometimes very, let's say, worrisome, because we have prominent sphenobasal veins and infratemporal vein, as you can see here in this slide, courtesy of Professor Kawase, that, as you know, has been the most popular neurosurgeon approaching that area. So take into account that sometimes you can have a very profuse bleeding coming from this very, let's say, variable anatomy. Sometimes just around the third division, you can have prominent bleeding from this venous structure. And this is what happened with our friend, the psychiatrist. We have a very intense bleeding of the extradural space. This is one of the slides giving some idea of the venous anatomy over here. And we just, in cases like that, what you can do is just opening dura mater, reflecting upward the temporal lobe, and that way you can very easily expose the lateral wall of the cavernous sinus. In this slide, you can see the prominent veins that are extradural, giving the explanation of why there was so terrible bleeding. So we just abandoned the extradural approach and moved to an intradural approach. In that slide, you can see the very easy removal of the tumor that was a trigeminal neuroma with hemorrhagic presentation. And you can see how, in this case, we fortunately managed to preserve the fibers of the trigeminal nerve. Sometimes you can find same concept, same pathology, in that case with a much bigger volume. You can see always the relationship with the carotid artery. We have to be very much aware of that. And this is the way we can, in that case, again, we understood that it was easier removing that from the intradural space. And at the right side, you can see after the removal, this is the third division. This is the second division, and the way we managed to preserve the nerves. The third possibility is related to those lesions that are at the same time extradural and intradural. If we look at the anatomy of the trigeminal nerve, we can see the trigeminal the intracisternal segment, then getting inside Meckel's cave, then getting divided into the first, second, and third division. And amazingly, you can see one of these lesions that are growing at the same time in several compartments, because trigeminal neuroma is the only tumor that can be at the same time intradural and extradural, intracranial and extracranial, because sometimes we see the lesion escaping through foramen ovale, so the lesion can be intracranial and at the same time extracranial. This treble shape is very typical in trigeminal neuroma, and I like to advise you to have a look, to take a look to this publication, 1999, Trigeminal Neuroma, Extending into Multiple Forces, Surgical Methods and Review of the Literature, Dr. Yoshida and Dr. Kawase. I met them, I feel a lot of respect to Professor Kawase, who is I can say a personal friend, and this is one of the occasions we met in Bali in a meeting, and I have this very nice picture. So do not waste the opportunity of having a look to this paper from Dr. Yoshida and Dr. Kawase. And this is one of the lesions. You can see this lesion that at the same time is extradural, but is also intradural. You can see here tentorial incision. This lesion seems to be very complex, but are really easy. You can get inside this component, and then following the tumor, you will reach the posterior fossa. You can sometimes coagulate or cut or clip according to the caliber of the superior petrosal sinus. You can cut tentorium, as we did here, but take into account where you are cutting the tentorium, because the fourth nerve is getting inside, looking for the cavernous sinus, usually in less than 1 centimeter far from the clinoid process. So take into account that, otherwise you will damage the fourth nerve. By the way, this is the third nerve. We have completely removed the tumor, and this is Sargicel just covering the anterolateral pontine region. This is the postoperative CT scan. And this is another trigeminal neuroma. And this is one of the rare instances for me today. There is indication of COC, cranio-orbito approach. You only need some limited zygomatic osteotomy, but in that case, the tumor had been following the first division and getting inside the orbit. That way, you have at the same time to do Meckel's cave exposure and orbital exposure. And this is what we did, trying to remove, see this huge extension inside the orbit. This is the postoperative MRI. We left some small remaining tumor over here at the area of the superior orbital fissure, trying to diminish. You can see also that part of the tumor left behind, some small part over here, trying to diminish morbidity of cranial nerves. But see what happened over time, this huge recurrence again occupying the orbit of Meckel's case, and now even reaching the posterior fossa. This is the tumor, but nowadays we try to do an transcranial approach. It can be also approached through endoscopy, but the extension to the orbit could be a limitation for that. So in that case, what we did was the craniotomy. With the craniotomy, this you can see the opening, the tumor. There is some layer of the tumor, and this is posterior cerebral artery. This is the brain stem. This is basilar bifurcation, and we took advantage of endoscopic assisted microsurgery, trying to remove the content inside the orbit. So that way, we managed to completely remove the lesion. You can see here this clean plane and how we had managed to remove the orbital content as well without a orbitozygomatic approach. This is a young patient with this tumor, in that case an atypical meningioma. See the extension of the lesion, the lateral extension at the cavernous sinus, but a lesion, let's say, feasible, a lesion that you can remove completely without much difficulty. This is the immediate post-operative scan with some pretty good removal, some small clot over here. The patient had some sixth nerve palsy that recovered little by little, and years after the patient had a recurrency after radiotherapy. So just going to the lesions that are at the same time extradural and also intradural, I think that we have to mention the extended middle fossa approach. Extended middle fossa approach is taking advantage of the anatomical possibilities offering by the petrous bone, in the sense of getting inside posterior fossa. And from the practical point of view, getting inside the petroclival region, the anterolateral region of the posterior fossa. And we have to do several steps. One of the steps is just the drilling of the petrous apex. What we are seeing here is the internal auditory canal. The dura mater has been exposed. This is a representation of the third division of the trigeminal nerve. This is GSPN, this is petrous carotid artery, and this structure is the superior petrosal sinus. We have to do several cuts at the dura mater. The most important, because it is giving you some idea of the anatomy, is a parallel cut parallel to the inferior face of the temporal lobe. That way, after opening, we will see one example later on. You will see the tentorium, right? So we have to cut again and coagulate the superior petrosal sinus. But if you have already exposed the third division and trigeminal ganglion, you can follow in some retrograde way the Gasserian ganglion. So you will coagulate and cut whatever is in your way, and that way you will expose the intercisternal segment of the fifth nerve. And we have to take into account in that particular point of the operation, because there is some this is more or less segment, the fifth nerve, and then there is some pronounced, and if you are not much accustomed to that anatomy, cutting the dura mater, you can cut the fifth nerve. And this is taken from one of the publications in regard to this approach in the early 90s. And this is from Dr. Sekar and Dr. Sen, one of the papers published in 1994. And this is the area you can expose to get inside posterior fossa. But I have to mention that this, well, let's say this area could be, this hole is one of the best scenarios we can find, because usually the opening is small, is also variable according to the anatomy of the patient. So indication for that approach has been very carefully, let's say, analyzed. We are seeing one of these good examples to my mind, a lesion that is growing at the same time at the petrous apex, petroclival, sphenopetrous junction. That is to say, chondrosarcoma growing at the bone and at the same time growing inside the posterior fossa. You can see the relationship with the fifth nerve, the growing displacement of the brainstem. So we will see several steps. This is one of the initial steps. We are at the right side and we are trying to identify the middle meningeal artery. What we have to take into account first is how variable is this anatomy. Why? Because sometimes the middle meningeal artery is isolated, sometimes is surrounded by prominent veins, sometimes is assimilated in a single pack with the third division, as happened in that case. So it was some, you can see a vein over here, and you can see how we need a dissector to split the third nerve. You can see the third nerve, and you can see at the right side the middle meningeal artery. So difficult to, sometimes even this initial step, difficult to be done. Then what we have to do is just the peeling. You can see the dissector doing the peeling. What we have here is the Gasserian ganglion, some CSF is coming up. We have coagulate over here, middle meningeal artery, and this is GSPN. GSPN can be very easily damaged because it's an completely extradural structure, and in older patients it can be misled because sometimes the folding of the dura mater are let's say mimicking a nerve, and it's difficult to differentiate. So now we are exposing, this is the third division and the Gasserian ganglion. This is middle meningeal artery. This is greater superficial petrosal nerve, and we are, by means of the peeling, we are just exposing the petrous bone. This is the petrous apex. And one important question is until which extent we have to expose the petrous apex and we have to do the peeling. You have to do the peeling until being able with this dissector, Rotron dissector in this case, to go around the petrous wedge, and doing that, it means you cannot go further and your peeling is satisfactory. So this is the way of completely exposure the upper and lateral surface, and by means of that you can start to drill. Just see that in that case we are drilling normal bone. The lesion is right underneath. You will see the drill getting inside. You can see, okay, resistance is less and the drill went down because we just found the tumor. So you have to drill around. You have to take the limit laterally, petrous carotid artery, posteriorly and medially, internal auditory canal, posteriorly and laterally, the cochlear structures, and medially we have some more relaxing structure, that is the petroclival dura mater. So we have to drill, and so we can expose. You can see the dura. This is internal auditory canal. You have to drill, take into account that you can go deep and you can provoke some bleeding of the inferior petrosal sinus. We drill around, drill and drill and drill. This is tumor. You can see the typical consistency of the chondrosarcoma. And in that case, we just drill out all possible bone. We have the dura mater, we have internal auditory canal, we have the medial structure, that is the petrous carotid artery with the GSPN. This is the third division, but we cannot see underneath unless we cut the third division. And the tumor was in continuity just because of the fact that by definition, chondrosarcoma is coming from the petroclival junction. So in that case, you can take advantage of the endoscopic assisted microsurgery, and this is the way you can take a look. And this way, we just realize there were some remaining tumor at the bone. Once you have removed, you have to cut the dura mater in that parallel fashion. We are exposing tentorium. We are reflecting a little bit the right temporal muscle. Okay, and this is a very important view. Because this is tentorium, this is extradural, this is the Gasserian ganglion, and you can see how the Gasserian ganglion going backward will lead you to the intradural and intracisternal segment of the fifth nerve. This is tentorium. So in that occasion, you can go that way, and whatever dura mater you find, you have to cut it, exposing the nerve and cutting tentorium and reaching the posterolateral segment of the, exposing the anterolateral pontine region. So now we are just coagulating the superior petrosal sinus, and we have to cut it. But I like to call the attention about how close the fifth nerve and dura mater are. So if you cut from above, you can very easily damage the nerve unless you are very much aware of this anatomy. See how close to the dura mater. We are just releasing that area. Okay. And we can cut dura mater. This is cutting tentorium. You can see the intercisternal segment of the fifth nerve surrounded by tumor. Okay. So we have protected the fifth nerve. We have spared with the dissector laterally the bulgy tumor at the anterolateral petroclival region. And in this safe area, where used to be the petrous bone, is where we just do the debulking of the tumor. And then with, of course, our microsurgical dissection, we have to remove everything. You can see that this is the pontine region. We are removing some tumor, very adherent, very sticky, not easy. And this is the last step of the operation. So this is the preoperative MRI, and this is the postoperative MRI with a pretty good satisfactory resection at the bone and also at the intradural region. Indication, any lesion that is at the same time growing at the petrous bone and inside the posterior fossa. This is a patient, old patient with recurrent chordoma that we remove by means of this approach. You can see the satisfactory removal even at the bony area. And there are some other indications for this approach. One of them is petrocleial meningioma. Actually, in my practice, I have not seen many cases amenable for one or another reason to this approach, because sometimes this approach is of course time-consuming and not without potential morbidity. And for a small meningioma, anatomical possibility for anterior laterally placed lesion, in that case at the pontine region. This is a cavernoma, but for cases like that, intrinsic lesion at the brainstem, we are more in favor of classical retrosigmoid approach that can expose and allows for removal in a very, let's say, straightforward fashion. So the second part of my talk could be about the role of endoscopy. Endoscopy is providing you a very good option in certain cases and complete different view, because this is the view of the petrous apex. This is the petrous apex, just from, let's say, in front view. You can see that we are at the left side. This is internal carotid artery, petrous apex, Gasserian ganglion, GSPN, that is converted into Vidian nerve, just crossing the bony area and just appearing at the nose. You can see the third division of the trigeminal nerve, and in summary, a complete different view, in this case, from view of the petrous apex. So, indication: lesions that are restricted to the petrous bone. We have seen several examples done years ago, but now we have to take into account the possibility of endoscopy. We saw a cholesterol granuloma case. This is another cholesterol granuloma case. And we have to see whether and until which extent the lesion is abutting the cortical bone and is close to the sphenoidal sinus. If you see the lesion, you see this thin layer, you can see how easily that lesion can be approached through endoscopy. We are working at the right side, and this is carotid artery, and we can see the way of very easily exposed cholesterol granuloma, and this is bottom right. You can see the removal of the lesion, complete removal by means of endoscopy. Chondrosarcoma. Chondrosarcoma, we saw just several examples of chondrosarcoma. You can see the relationship with the petrous carotid artery, the lesion occupying basically the bone, as you can see here. Very important, the relationship with the internal carotid artery, and this is removal. We did not attempt an aggressive removal in the vicinity of the carotid artery. There is some small tumor over here, because chondrosarcoma usually is a low-grade tumor that has a lot of radiosensitivity, and being treated with radiotherapy, if there is some small remaining, you can have a very safe and satisfactory resolution of the problem for the patient. We always have to look the best for the patient, not only just satisfy our ego in the sense I did remove that completely, although I had some problem with the carotid, we have CSF fistula, and so on. So I think we have to try to be, let's say, judicious. Second example could be lesion of the petrous bone with extension at the same time to posterior fossa. This is another example. This is another patient with sixth nerve palsy, a young patient with a lesion growing at the petrous bone and at the same time, after penetrating dura mater growing at the anterolateral intradural petroclival region. You can see the tumor over here, and important to see the relationship with several structures. A very important key is whether or not the lesion is extradural or intradural. Sometimes it's not easy because this lesion seems to be intradural, but fortunately was extradural. Also, the relationship with the petrous carotid artery, and take into account that the lesion are going to the internal ear structure, and very important, as you can see here, this is the jugular bulb. You will find the lesion close by. So this is something you have to take into account before making the choice of your microsurgical or endoscopic approach, and also trying to see until which extent you will be aggressive. In that case, we did endoscopic endonasal approach, middle and upper right turbinectomy, transclival, transpetrosal approach, inferolateral petroclival corridor with nasoseptal flap, and we had prepared spinal drainage just in case there was let's say, high debit CSF fistula. And well, we were very lucky because what we are seeing here is dura mater after removal of the tumor. The lesion was completely extradural, and we did a pretty satisfactory result. This is the plane of the dura mater, MRI after removal. The patient was sent for radiotherapy, and this is the last MRI control with pretty satisfactory images. There can be some dubious lesion in the vicinity of the jugular bulb that we didn't try to be, let's say, very aggressive. Another possibility, intra and extracranial lesions. This is a very young patient, 18 years old patient with pain at the left side of the face. Look, this lesion occupying intracranial portion at the lateral aspect of the cavernous sinus, and see this huge lesion growing inside the infratemporal fossa and pterygopalatine fossa. This is more or less the opening of foramen ovale. At the beginning, we did suspect trigeminal neuroma, but the lesion was big and had been growing very rapidly, so we had some doubt about the histology. You can see the lesion just getting inside posterior fossa. And in lesion like that, if you want to do a transcranial approach, you have to plan two different approaches. One transcranial approach and another transfacial infratemporal approach, very complex, by the way. But endoscopy is giving you the chance. This is somewhat aggressive for the lateral aspect of the nose, but this aggressiveness is almost nothing compared to the craniotomy. And this is the postoperative MRI after subtotal removal, because unfortunately the lesion was very, very infiltrating. It was a sarcoma, and we managed to remove as much as possible. But in any way, see how we managed to remove the intracranial component and a very important part of the infratemporal and pterygopalatine fossa. This is another example. This is a classical trigeminal neuroma, some growing interdural, as we mentioned before. But if you see over here, there is some extension. See this that extension toward infratemporal fossa, because the lesion is following. Remember the paper from Dr. Yoshida and Dr. Kawase is following the nerve. So for cases like that, endoscopic approach is a good indication. We did this approach with Dr. Cárdenas and Dr. Ariel from Seville, that are very good friends and real expert in this approach. And this is the way we are working at the left side. This is some part of the trigeminal neuroma exposed. And this is bottom right, the way you can expose the extracranial content, and you can follow that. This is a very beautiful slide. We are working at the left side. What we have here is the lateral wall of, the medial wall of the cavernous of the Meckel's cave. This is the lateral wall. This is the interdural context for that lesion. This is dura mater of the temporal lobe, and we are just seeing some small tumor located at the porus trigeminalis, trying to remove that part of the tumor. Needless to mention that the more the tumor is getting inside the intradural structure, the more complicated this approach is. But in any way, for that case, that was 99% confined to the interdural space, and also following through foramen ovale the third division, this approach was pretty satisfactory, as you can see in this postoperative MRI. So this is another case, 73 years old, recurrent chordoma, as you can see here. We try to, after removal of the initial chordoma more than 10 years before that operation, and due to the context, we try to do some judicious and partial removal by means of endoscopy. You can see carotid artery over here. We did a very satisfactory operation. This is the immediate postoperative CT scan, but we don't have MRI because in the immediate postoperative period, the patient just had a brain infarction, MCA infarction, and well, in spite of thrombolysis, the patient unfortunately died. Our explanation that probably due to the age of the patient and due to probably some atheromatous internal petrous carotid artery with the manipulation of the carotid that we did, that manipulation, probably some emboli went up and occlude the vessel. This is a very sad, very unfortunate result. Well, this is the last slide summarizing in regard to microsurgery and endoscopy. The first message is about anatomy, how important anatomy is, and I do encourage you all, if you are interested in that anatomy and in that surgery, to go to the anatomical lab and attend anatomical surgical courses related to this area. We have seen that microsurgery and endoscopy are a good approach. I think we have to try to master in as much as possible both of them. I think the senior colleagues, I'm now senior, the majority of the senior colleagues had a lot of reluctance to embrace the endoscopic technique. It is not easy. I had to overcome this learning curve around 15 years ago, but I'm very happy about doing many endoscopic approach to the sella and many other pathologies. And at the same time, the young fellows are very much excited with endoscopy, but they are not paying much attention to the classical open techniques that sometimes are really necessary. Maybe someday, if Dr. Noor wants, we can talk about some approaches that are very, very, very necessary, as for instance, transcondylar approach. There are several approaches you have to master. I mean, open approaches if you want to deal in some appropriate way with with those cases at the skull base. In any way, by means of microsurgery or endoscopy, you can get access to the petrous apex bone, petroclavial region, pontine region, lateral wall of cavernous sinus, and of course, infratemporal and pterygopalatine fossa. So the last slide is in regard to microsurgery versus endoscopy. I don't want to have that impression that this is the right way, just fighting microsurgery against endoscopy. And so that is something that we see very much in international meeting among friends. And well, I don't think this is a boxing match. As you can see here, Charlie Chaplin just fighting. I think we have to first just work with the sort of technique you are trying to master, and you feel more comfortable and more confident to solve the problem of the patient. In our case, we always wonder about these 5 points. Until which extent the lesion is abutting a sphenoidal sinus. The more the lesion is close to the sphenoidal sinus, the more easily the lesion can be removed by means of the endoscopy. Is there intradural growing? Intradural growing is a sort of limit because maybe you can feel more comfortable doing the approach transcranially, but if the lesion is not growing intradurally, I think endoscopy is pretty good. How posteriorly the lesion is placed? Is the lesion going to the jugular foramen? If so, maybe you have more chance to control a potential bleeding by means of transcranial approach. And this is very important. Is there vascular encasement? Vascular encasement is always worrisome, and is worrisome in some particular circumstances. One of them, when the patient has been operated on before, and second, even more important and more worrisome, if the patient has been operated on and underwent radiotherapy. Because in cases like that, there is something like a fuse mass, and it's difficult to spread the tumor from the carotid, and you can have some intraoperative rupture. So this is my last slide in regard to the consideration of the microsurgical and endoscopic approaches to that area that is beautiful. Well, we are seeing a very happy end, you know, bottom right, and this is the very happy end I wish for all of you if you are going to deal with this lesion. Thank you very much. I don't want to finish without again thanking Dr. Maria Noor for her enthusiasm and her kindness to invite me to being among you all. Thank you very much.
Thank you very, very much, sir, for your time, sir. Honor and pleasure is all ours. It's like a dream come true to have the privilege of having you here with us. Sir, again, really, really big thanks to you. I don't think that words can actually, we cannot put it into words what we feel about having you here, the honor and the immense learning experience that we have. So again, thank you very much. And we will be so happy and honored to have you again. Sir, we will be looking forward to invite you again to any day and any time which is convenient for you, and to discuss any of the topic of your own choice, because we are all looking forward to discuss more surgical approaches with you. So the lecture was so elaborate and everyone's so happy. Yes, sir. Please, sir.
Thank you. Thank you very much.
Thanks a lot, sir. There are lots of compliment and messages for you coming in the chat box. Thank you a lot. Thank you. A big thanks, and everyone is so much intrigued. So again, sir, thank you very much, sir. I have just one question, sir, regarding the trigeminal schwannomas that we deal with. So we obviously divide. There are so many classification systems like the Jefferson system, the Summy system, etc. But so for the double type of tumors, obviously there are so many things that we need to consider regarding those double types of tumors: the size of the anterior and the posterior pole, and also their relation to the cavernous sinus, and if it is the posterior pole, is whether or not it's compressing the brainstem, and whatever the symptoms are. So usually we think that the endoscopic approach will be appropriate for those tumors which are getting the bit of foci in the Bacchus cave, so that we would go with that and not for that those tumors with a larger posterior lobe. But sir, would you recommend combining a transcranial approach with an endoscopic approach, like we address the anterior pole through the endoscopic approach and address the posterior pole using the retroscopic approach? What's your view regarding this?
Well, thank you very much for your comment. You mean in regard to the possibility of doing a combined approach, that is to say, endoscopic in one side or microsurgical in the other side? Well, I wouldn't say it is necessary. Two points. One of them, of course, everything depends on how much you rely on your possibilities. Well, from the microsurgical point of view, I can say that you can remove the lesion in one shot, irrespective of the size of the lesion, irrespective of the extension of the lesion. You have two components. One of them is the component at the lateral wall of cavernous sinus, that is the interdural component. We say Meckel's cave. But the bigger the lesion is over there, the more is the ease to get inside the posterior fossa, because the lesion itself is giving you the approach. You don't have to drill anything because the tumor has enlarged, let's say, the porus trigeminalis. Anatomically, this is what is getting enlarged when the tumor is getting bigger and bigger. And this big opening is leading you to the posterior fossa. So if the lesion, you are gathering that the lesion is a complex one because of the component at the lateral wall of the cavernous sinus and also at the posterior fossa, one single shot is good enough. In regard to endoscopy, well, I can tell you that I've been maybe devoted to those lesions for more than 30 years. And I have done many of my cases by means of microsurgery. And for endoscopy, there are centers with the top experience, Pittsburgh, for instance, and maybe they can deal with some, let's say, in a very easy way, since the beginning, and just removing, in the example I put, that for me is not much complex. I mean, removing the lesion and following the lesion toward posterior fossa, just cutting tentorial incisura, and this is a wonderful approach. But maybe this approach can be done 100% endoscopically. For cases like that, in my personal experience, I have to be honest with you all, I do not feel confident enough. And the second part, that is the intradural component, I don't see that very easy to be removed. So if you are trusting in your endoscopic technique and you feel you can do everything in one single shot, it's okay. If not, instead of, this is not my case, for complex intradural cases, I'm not feeling much comfortable. I don't have enough experience, but I do have some experience in the transcranial approach. So in my case, if I would do that transcranially. If you are hesitating and you are thinking about endoscopy and microsurgery, just do everything by means of microsurgery, because endoscopic approach to Meckel's cave is not an easy operation, can be risky operation. It provokes some distortion of the anatomy and the function of the nose. We have to be aware about that. And on the contrary, you can very easily reach the trigeminal ganglion by means of transcranial approach. It's not a difficult operation, but you have to do that. You need some experience. You have to go to the anatomical lab. First time I went to the anatomical lab after reading papers and so and so. Well, I couldn't understand. Basically, I couldn't understand the relationship between the middle meningeal artery, the third division of the trigeminal nerve, the petrous carotid artery, the cartilaginous layer. I couldn't understand that. I went to the anatomical lab. I used to work with Dr. Valencia, a maxillofacial surgeon, ENT surgeon in Granada, and because we used to work as a team, and we just understood the anatomy, and we were able to deal with the cases.
That's amazing, sir. Thank you very, very much, because this is important a question that is quite a debatable thing, that the combined approach is one of the things that people usually discuss a lot. There are a few questions, sir, in the chat box. There is a question from Dr. Faiz. He wants to know, thank you very much, sir. What is your advice for cholesterol granulomas and drainage to avoid recurrence?
Sorry, for trigeminal neuroma, where?
What is your advice for cholesterol granulomas?
Okay.
Yes, and drainage to avoid recurrence.
Okay, thank you very much. This is a very important question. Cholesterol granuloma is very frequently seen in our practice, and I think there are several main points regarding that. If cholesterol granuloma is an incidental finding, you don't have to touch at all the cholesterol granuloma. You have to just wait and see and follow the patient. If the cholesterol granuloma is provoking symptoms, not unfrequently related to the internal ear structure and or even facial nerve and or even sixth nerve, if there is, let's say, there are clinical symptoms and or the lesion is progressively growing, you have to do the operation. In those cases, I have done, let's say, cases by transcranial route, but nowadays we don't use the transcranial approach any longer, because simple transsphenoidal endoscopic approach is good enough to solve the problem.
Thank you very, very much, sir, again for this question. Sir, there is also another relatively lesser known entity called the petrous apex cephalocele, or the Meckel's cave herniation. We have just read about it, never seen that pathology. Anyway, the Meckel's cave herniation, the petrous apex cephalocele. Sir, I've been reading about it, that if it is asymptomatic, just it's a no-go area. So if it is asymptomatic, just leave the Meckel's cave herniation, or what is known as the petrous apex cephalocele, and if it is symptomatic, then you have to look for surgery. So I need your kind view on this Meckel's cave herniation, or the petrous apex cephalocele that we know about and never seen it.
Okay, thank you very much. Well, I have to mention that I'm very happy because I was appointed clinical director of cybernight unit in the south of Spain, in Malaga, wonderful facilities. I think radiation therapy and stereotactic radiosurgery are very much, let's say, are friends of neurosurgeons and neurosurgical pathologists. The decision is not easy at the Meckel's cave, because first, you have lesion over there that sometimes are asymptomatic lesion and are asymptomatic, let's say, incidental findings. In cases like that, you can do the operation. If the patient is young, you can do radiation therapy if the lesion is small. And you can also wait and see. And I think that before making the decision we have to take into account several things. One of them is until which extent the lesion is big or small, the lesion is provoking symptoms or not. If the lesion is provoking symptoms, you have to do something. If not, maybe incidental finding, according to the size, you can also have the possibility of wait and see. The second question is about the age of the patient. Over there, sometimes trigeminal neuroma is a very common finding over there, but also meningioma is a common pathology over there. What is going on about incidental meningioma? What the literature is saying that more than 80% of the cases are going to grow sooner or later. So you have to take that into account. It means we are like, like neurosurgeon and physician, we are always like playing card. We just are gambling with probabilities, probability of this or that. So the probability of a lesion to continue growth, case of meningioma, that is one of the best studied according to the clinic, to the natural history, is to grow. If the patient is young, you have to treat the patient because otherwise you have a more than 80% probability to regret of not having done that. The third issue, so you have some possibilities. You have a patient, 82 years old, with a small lesion at Meckel's cave, asymptomatic. You have to do nothing. If you have this lesion in a patient who is 15 years old and the lesion is 3 centimeters, you have to do something. What to do? The younger the patient and the healthy the patient, the more the probability is successful by means of useful, taking into account the life expectancy of the patient. Radiation therapy is good, but sometimes you have to try to see what is going to happen. If you have a lesion that is atypical, or you have several lesions, and so maybe you have to reserve radiotherapy because you can reoperate the patient 1, 2, 3 times, but maybe you don't have the chance to re-irradiate the patient 3, 4, 5 times, right? So you have to take that into account. And the last but not the least important point is the will of the patient, the desire of the patient, I mean. Some patients are phobic to the operating room, something clear, radiation therapy. Some patient doesn't want to hear anything about radiation. Surgery is the option. So it's very important before giving the advice in cases in which surgery, radiation, wait and see policy, these 3 possibilities are equal and they are reasonable. Before saying anything, you have to hear what the patient wants to do. You offer the possibilities, you hear the patient, and you put in the same way along with the desire of the patient. This is my humble trick to try to be, let's say, right in that decisions.
Thank you very, very much. I think it's a very important point, sir, that should be noted, and it's like it's very wise decision. Thank you very, very much, sir, for sharing these amazing points and all these amazing approaches to to offer the best possible management plan to the patient. So there is also a question over here that I can see. Wonderful presentation, sir. Very, very much. Thank you very much. In your experience, how would you approach the tumor recurring on the Meckel's cave via endoscopy or microscopy? Do you often use the navigation for recurrent tumors at all in that area? How is the rate of the leak in your experience? So he's basically asking about first the recurrent tumor in the Meckel's cave. How would you like to approach? Whether you would like to approach through endoscopic approach or through the microscopic approach? And do you often use navigation for recurrent tumor in this area, and what is the rate of leak in your experience?
Thank you. Thank you very much. Well, I think that neuronavigation is a very important tool. in the de novo case, maybe you do not need neuronavigation because you are guided by the anatomy, and you have a very good landmarks. One of them, of course, we have mentioned that middle meningeal artery, and then the third division of the trigeminal nerve, gastrin ganglion. You have to see that always anatomy is very constant, right? You have to see, you have to just to be, once you have get there, you have to be aware of the issue of the dissector just going along the bone. Why? Because you have the possibility of a non-covered carotid artery, and second, you have the risk of damaging the greater superficial pretorsal nerve. That is an extradural structure, and you are going to face that very soon in your approach. So, I mean, in summary, for de novo cases, maybe neuronavigation is not to be very helpful. It may help, of course. You have the carotid, not only for the carotid at the petrous area, but for the carotid at the intracavernous area, because the tumor is always in contact with the carotid. So neuronavigation can be helpful. For recurrent cases, I think this is very important. I think we have some parallel comparison. We do many pituitary cases, cellular cases. For de novo cases, I very seldom use neuronavigation. In case of conchal bone, that is to say, you are opening a sphenoidal bone, you don't see anything. You can get lost, completely lost, and you don't know where to drill, because the endoscope just provokes some distortion. So neuronavigation is indicated. Another case for de novo cases, flat cella. You don't have any bulging cella, so you don't have where to drill. I had an Arraez. I have a talk about management of carotid lesion at the skull base. I'm saying I'm afraid I have this talk because this talk is coming from my mistakes along my professional life. So one of the problems I remember, it was in a patient, de novo case, very young patient, small cella, flat cella, and I drilled just right on the carotid artery. Fortunately, it was a very small bleeding, but I learned the lesion. But in recurrent cases, the last one was operated on 2 days ago. At recurrent cases, I always do the case with neuronavigation. I remember one case, a recurrent pituitary adenoma growing inside cavernous sinus, reoperation, a lot of scar, just some invasion of the cavernous sinus, no neuronavigation because technical issue. Okay, the patient had been at the waiting list for a long period. Okay, let's do the case. Carotid damage, right? So for those cases, you have to do the operation with neuronavigation. If the patient has been previously operated and previously irradiated, well, you have to have some extra care, because very easily the lesion, even craniopharyngioma, we had problem with simple craniopharyngioma because of previous operation and previous radiation and very much adherent tumor to the carotid artery, right? So in case you have to go for salvage surgery after recurrency, depending on the recurrency, you have to take into account the possibility of neurosurgery. Maybe you have some small tumor that is growing little by little. We are talking about millimeters. Maybe radiosurgery, of course, cyber knife or gamma knife is a very good option. If the tumor is an aggressive tumor and you have to try to do an aggressive removal nearby carotid artery. And so my personal preference is transcranial approach, but I don't want to fall into, okay, what I'm doing is right, what I'm not doing because I'm not an expert is not right. It depends. There are wonderful neurosurgeons mastering in endoscopy much more than me, and maybe for them that possibility is good. In my case, well, 100% believing what I'm going to say. In spite of the beauty of endoscopy, of marvelous change in neurosurgery, new era in neurosurgery, the maneuvers, the possibility of managing tissues, the possibility of managing the tumor, dissecting, coagulating, preserving structure is much more with microsurgery, because some issues regarding to the distance, regarding to, let's say, you have to operate with instrument through the nose, you don't have some open space, you have the distortion of the endoscope. So for several reasons, at least for me, delicate cases, if I can make the choice, I'm in favor of microsurgery. But in my case, regarding, I'm very important for you all because you all are very, very, very young. You have to do not what Dr. Arraez is saying or what whoever else. You have to do the approach you are trusting and you feel confident, because this is to be the best for the patient. Even this is not the last fashion approach, right? Regarding to the other issue, regarding to CSF fistula, well, when we are doing a transcranial approach to Meckel's cave, we usually, if you have to do an intradural approach at the same time, you can release CSF after opening dura mater. If you are going to do a complete extradural approach, you have to put a spinal drainage, because it's a spinal drainage along with corticosteroid and so on. So is allowing you the retraction without damaging the temporal lobe. That is the most frequently manipulated. So it means that if you have opened the dura mater at the skull base and there can be some CSF fistula to the bone or the eustachian tube that can be open and so on. So you have to keep the spinal drainage for 5-7 days, and that's all. So you don't have in transcranial approach, the rate of CSF leak is not high.
Thank you very, very much for the very elaborate answer. So do you use the Doppler ultrasound to locate carotid like in the endoscopic approaches? So do you use that?
Yeah. This is a tool you have to do very close to you. And basically to identify the carotid artery when you are dealing with the tumor at the intercavernous space, because at the medial and inferior aspect you will have the carotid artery.
Exactly. So thank you very, very much. This is a very so there are so many thanks and wishes for you in the chat box as well, sir. So again, thank you very much for all these discussion session as well. I know you are very, very busy and we have taken a lot of time from you during this very morning. Thank you very, very much, sir. And again, thank you so much for staying up for all this discussion and for this question and answers and elaborating every point of it. And I'm very happy that all these recordings are also available on YouTube, so that we can just see them again and again, and everyone can actually take benefit from your very wonderful elaborate talk, sir. So thanks again, sir. There is also a something new that I really wish to add in this webinar, sir. Like when we are in the conference, we take a group photo at the end. So I wish if we can take a group photo of our virtual attendees too in Zoom, if you like.
Okay, thank you very much. It will be my pleasure. I just I'm seeing some names, very good from very good friends from Spain, Dr. Mario Gomar. I'm seeing Dr. Enciso, excellent Peruvian neurosurgeon, who is spending some time with us. Also, Dr. Victan Kriston from Indonesia. Well, many friends over here. Big hug. I do salute you all, and I wish you a very happy weekend. Dr. Noor, more than honored and more than happy, and always willing to participate in this wonderful webinar. Thank you very much.
Thank you very, very much, sir. Thank you very much for giving us this honor of being with us today. So again, sir, I really wish to request you to give another talk, sir, whenever it is convenient for you to deliver a talk.
My pleasure. My pleasure. I hope you will enjoy. My pleasure. We will keep in touch. All the best.
All the best. Thank you very, very much, sir. Thank you so much.
Bye.
Thanks for the advice. I've also shared the advice. So thank you very much. I've shared all the best, sir. Thank you. Thank you so much, sir. It was a huge honor for us indeed. Hello, everyone. I have shared the links to download your certificate in the chat box. So kindly just send me a request to give you the access, and I will share the access to you in a couple of hours. So again, thank you very much. You can download your certificate now. So, sir, it was an honor to have you here. And everyone, Professor Mario Gomer, thank you very much. It's so kind.